This lecture is on seizures and epilepsy. Seizures are the bursts of synchronous neuronal activity that give rise to motor, sensory, and cognitive abnormalities during that burst. Epilepsy is recurrent seizures, so in other words, more than one occurring. There are different types of epilepsy. All forms of epilepsy are going to have seizures. Not every seizure is going to be a case of epilepsy though. So in order to have epilepsy, it's recurrent seizures. On this first slide here, we can see a little bit of seizure activity going on by EEG, or electroencephalogram, or electroencephalography. So they put little electrodes on the head, and they're going to measure these tiny microvolt changes in electrical potentials that are caused by the electrical activity of nerve cells within the brain. So of course they have to measure that activity in the brain through the meninges, through the skull, through the scalp, through the hair if it's there. And so we're looking at very small changes. But you can see these kind of bursts of synchronous activity and high amplitude on the EEG as opposed to very low amplitude. So this would be normal EEG, and your two channels would be decorrelated, so their activity wouldn't match one another. Whereas in the case of a seizure, what you're going to see is synchronous bursts of activity across multiple channels. So imagine each of these lines is a different location on the scalp. In a seizure, a large number of neurons are firing at the same time. So they're firing bursts of action potentials, and that synchronous firing is what creates this large amplitude potential on the EEG. In the first part of this lecture, we're going to talk about the different types of seizures that are there and the prognosis for the seizure disorder depending on when it arises. In the second part, we'll talk about the pathophysiology of seizure activity and some of the treatments that are available. We do have fairly successful treatments out there. So this story will end a little better than most in this class. When we're talking about epilepsy, we're talking about recurrent seizures. And those seizures can create motor abnormalities, they can create hallucinations or sensory abnormalities, or they can cause loss of consciousness or change in the conscious state. Okay, so seizures are going to be those bursts of synchronous activity. In this slide we can see normal EEG and then EEG during a seizure, and I'm just going to go ahead and blow up that seizure activity there. And there, so each one of those lines is going to be a different electrode. And because multiple neurons in different regions are firing at the same time, multiple electrodes are going to show those synchronous bursts. Some of them will be quick, some might be a little slower, but they're still going to match up pretty well. So bottom is showing us those large amplitude deflections. That's characteristic of seizure activity. And we're going to need an EEG in order to actually diagnose seizure. There are other times when abnormal motor activity occurs or abnormal sensations occur or there's loss of consciousness, but you can't ever detect a change via EEG. And this is a psychological condition that we call psychogenic non-epileptic seizures. Psychogenic meaning that they arise psychologically as opposed to physiologically. So since we don't have that EEG to confirm it, we can't really say that these are physiological seizures, so we call them psychogenic seizures. Now when you have recurrent unprovoked seizures, this is epilepsy. So a single seizure event, let's say following a head injury, that wouldn't count. It's only one event and it was provoked by a blow to the head. Unprovoked seizures are not brought on by some other stimulus. These just arise spontaneously. Now epilepsy is going to be about the fourth most common neurological condition out there. It has an incidence of about 67 people per 100,000 each year. About 1 to maybe 1.5% of the population are going to have epilepsy. No differences across age or the sexes. There's a special case called status epilepticus where we have prolonged seizures that will last greater than 30 minutes, and you'll have multiple seizures. So that long duration, that's what makes status epilepticus. So in this example here, we're looking at recurrent seizures, so we have epilepsy, and these arose early on, and they're leading to those jerks. So here we're going to have the severe myogenic seizures during infancy. And these have fairly poor prognosis, which you can see in the notes. So those involuntary movements, those are caused by the seizures. She's been induced into a coma here to help keep the seizure activity down. Now, not every seizure is going to create motor abnormalities, but many of them do, because a lot of our brain is dedicated to movement. And so anytime you have seizure activity in motor areas of the brain, you get motor output. But it's not in a coordinated manner, it's not under control. So this is an example of a simple partial seizure. So it's partial in that only one or a few areas of the brain are affected, not the entire brain. That would be generalized. You'll see facial tics here. All right, so we're getting motor output, but we don't have a loss of consciousness. So this young man is aware of what's going on. He'll remember it after it's happened. What he has is this bout of uncontrolled motor activity, and there it just relented finally. And he's aware of that. It didn't affect his consciousness, and that's what makes it simple. So if consciousness is preserved, you just have some abnormal motor output or sensory perception. In the case of a complex seizure, that's where we have altered consciousness. So there might be large periods of the day missing, or I guess little periods that will add up that are missing. But in a simple seizure, consciousness is preserved. Now compare what you just saw there. Now we'll let it finish, otherwise I don't think it'll export properly. So we'll let the movie finish here. Oh, if that wasn't sad enough, I think it was Christmas when they filmed this. Not sure why I told you that. All right, let's move ahead. So generalized seizures here. Now we're going to see ourselves a grand mal seizure. So generalized meaning diffuse, so a large area of the brain is going to be affected. Since we're affecting a larger area of the brain, what we should expect is a larger area of the body to be affected with the motor output. Only with very focal changes in motor output are we going to get the simple seizure that we just saw. But now all the brain is lighting up, so his entire body is going to get excitatory input here. So you're going to see a tonic and clonic phase here. So tonic is when he has that really high muscle tone, and then we're going to see bilateral jerky contractions following that. So you'll notice much greater area of the body affected. That's because it's generalized, and as such the symptoms are far worse. So something like a grand mal seizure is going to be a medical emergency that's going to require care, but the simple partial seizures are something that are just going to cause a very isolated event there. So there's our clonus there. Now the other type of generalized seizure here really only affects consciousness, but affects it far more profoundly than we see in a complex partial seizure. In a petit mal seizure, the patient is completely unresponsive, so it's a complete loss of consciousness rather than an alteration of consciousness. So think of partial and generalized as really being two very similar things, except generalized affects a larger area of the body. And into those two categories, we can either have an effect on consciousness or not. If we don't affect consciousness, and we're affecting a very small part of the brain, then we have a simple partial seizure. You'll have some motor abnormalities, sensory abnormalities, both. Complex affects consciousness. Same thing for grand mal and petit mal. So a grand mal seizure, we're going to see that motor aspect of it, very pronounced motor output, and petit mal is going to be just for consciousness. Now the risk factors for epilepsy are highly variable, but they all kind of center around synaptic transmission and the activity of neurons. Now, clearly there's a genetic basis in some cases, and we do see an increased risk in first-order relatives of epileptic patients. So genetic abnormalities that make neurons more excitable are going to make the neurons prone to seizure activities. So some of the genes that are going to be targeted are the voltage-gated sodium channels. So if we increase our sodium current, what that's going to do is depolarize the neuron. Another target would be proteins involved with the release of neurotransmitter. Of course, if we don't release vesicles, we don't spit out neurotransmitter. If we can more easily release vesicles, then we can release more neurotransmitter. This is going to depend on which neurotransmitter it is, whether it goes one way or the other. So this isn't as clean of a story, but we also have mutations in GABA receptors. Now these are chloride channels, and these are inhibitory. So if we decrease our inhibition, we're going to excite neurons. Then there are mutations in kinases, proteins that are involved in gene expression, so it's a mixed bag. But you do have some ion channels. You got some neurotransmitter receptors, but it's highly variable. There isn't just one case here. And that makes sense because there are so many ways of exciting and inhibiting neurons, and if you break any of those, you can affect the excitability and thus make neurons more likely to have seizure activities. There's a variety of triggers as well that can cause the onset of seizures. Of course, we're probably all familiar with the flashing lights. That's going to create kind of phasic bursts of neuronal activity that might start off a seizure. Anytime there's illness or even allergies, things that are going to cause an inflammatory response, that can increase neuronal activity. Remember that if we have inflammation, that can lead to hyperactivity of neurons. We've already discussed that in Unit 1 and probably 2 as well. Excessive heat can also lead to seizure activity. Just heating up a cell increases its metabolic activity, and there can also be some pH dependence there as well. We're going to get into that in just a little bit. Stress can seem to increase the onset of seizures, poor nutrition, lack of sleep. So there's a variety of risk factors here. Now, as far as making the diagnosis of seizure and epilepsy, we're going to need to see that abnormal EEG. We don't want to. We need to see the high amplitude deflections across multiple channels that are indicative of that synchronous bursts of neuronal activity. Now, you don't always see seizures having those bursts, and you don't always see those bursts going along with the abnormal signs as well. So sometimes they don't always go together, but oftentimes they do. So this is the principal way that we'll make that diagnosis. As far as getting an idea of what might be causing the seizure activity, is it epilepsy or is it something else? Well, then we can do some other diagnostics, like a lumbar puncture to look at CSF. Let's say we are extremely hypoglycemic. That's a fairly easy fix. We go have a piece of cake. But if we're hypoglycemic, our neurons are of course going to use sugar to make ATP. And that ATP, acting through the sodium potassium ATPase, is going to keep our membrane potential lower. This is going to help establish rest. If we run out of ATP, in the case of hypoglycemia, so if ATP levels drop, we're not fueling our pump, our membrane potential is going to move toward 0 millivolts. It won't hit it, but it'll move toward it. In other words, it will depolarize. So this is going to make neurons more excitable. You might also find an excess of glutamate. So perhaps there's a glutamate transporter issue, or there's an excess release of glutamate, maybe because of mutations in those genes that we went through a couple slides ago. So some of the genes associated with the fusion of vesicles. Or you might have infection. Infection can lead to inflammation, and inflammation can lead to excitation of neurons. There might also be mass lesion or vascular events that are leading to this seizure activity. If you go back in your notes from Unit 1, you'll see that seizures can arise in all of those states, whether it's infection or brain tumor, or even during any neurodegenerative disease. During the later stages, you can see seizure activity. So if you have a tumor growing and occupying greater mass and putting pressure on neurons, that can stimulate them too. If you rub your eyes, you'll see colors. Even though your eyes are closed, it's just the pressure. Pressure pushing on cells and forcing open ion channels so they depolarize. And when we stimulate our retinal ganglion cells, we see colors. It doesn't matter that it's pressure causing it or light, we still perceive color. And so the pressure from that growing tumor is going to stimulate the nearby neurons, and so they'll fire bursts of action potentials. And then they count to 10. Of course, vascular disease can also cause this by, again, depriving the neurons of sugar, oxygen. They run out of ATP. Depending on the severity of epilepsy, we're going to see a difference in survivability. So the more severe the epilepsy, the more severe the increase in mortality rates. And it's often the case that we can't explain the death. Death sometimes happens during prolonged seizures. It may be because of respiratory issues, so problems with breathing. It could be because of myocardial infarction. In some cases, we don't know. But undoubtedly, the more severe the epilepsy, the higher the mortality rate. So if we look at the data that are shown here, on top we're looking at the mortality rate comparing different ages, so pediatric, young adult, elderly, and then everyone all together. Now, in both cases, on the left there, you're looking at just epilepsy, but it's not status epilepticus. So the seizures are less than 30 minutes. On the right there, status epilepticus. So the seizures are lasting 30 minutes or greater. I've just filled in the ends for you there so you get some idea of sample size. So the older you get, the worse it is. We can see that trend. But what we can also see is that in the patients with status epilepticus, mortality rates are higher across the board and across all ages. So getting old still sucks, but in this case we're adding on a new layer of suck, and that would be status epilepticus, more severe epileptic activity. On the bottom, they're just looking at how many required treatment, and those that were treated, what was the mortality rate for there. So the more severe the seizure, even in those who had non-status epilepticus seizures, so briefer seizures, but when they were severe enough, when they caused severe enough symptoms that they needed treatment, they needed some sort of anti-epileptic treatment there, those more severe seizures had higher mortality rates. And those that just remitted spontaneously and didn't require any treatment, the less severe seizures, that is, in the open bar there, you'll notice you don't even see it, it's 0%. Now there's also alterations in mood. So you see higher evidence of depression and anxiety, and accompanying that, suicidal ideation, depending on the severity of seizures. So we're going from uncontrolled epilepsy, poorly controlled, well controlled, and then healthy control. It's going from left to right in each of those. And you'll see whenever we have uncontrolled or worse seizures there, there's higher rates of depression and anxiety and suicidal ideation. So that likely explains the elevated suicide rate that we see in epileptic patients. The good news is epilepsy can remit spontaneously. About 40% of the time it will remit spontaneously. And it really depends on what's causing the seizure. So if they arise due to, let's say, overheating or rapid changes in body temperature, like we see in febrile seizures, these are fairly common in very young children, and those have excellent prognosis. So as long as they're fairly brief, there's no association with future seizure activity. As long as you're having epilepsy onset that's either, well, that should, as long as you're out of that window, so greater than 2, well, it should be greater than 10 and less than 2. So as long as you're not in that window between 2 and 10 years of age, as long as your epilepsy doesn't really have a clear cause and you're able to control it, that ability to control it and treat it is going to undoubtedly improve your prognosis. And so that's what these data are showing us here. If you treat, in this case they're treating with benzodiazepines, so those are going to increase the activity at GABA receptors. So we heard about GABA earlier. GABA is an inhibitory neurotransmitter. So benzodiazepines are going to increase GABA-A receptor activity. In other words, they're going to, we'll think of it as decrease the membrane potential. We'll talk about what it actually does next semester. So we got 2 groups that we're looking at and 2 things that could have happened. They could either live or die. One group received benzodiazepines within 10 minutes of seizure onset, and the other group received benzodiazepines after 10 minutes. So at 10 minutes or after, they call that untimely. They didn't get the benzodiazepine treatment within 10 minutes. So the treatment, the group who had that, the group who received benzodiazepines within 10 minutes, 100% lived. And for those who received benzodiazepines after 10 minutes, that's when we start to see mortality rate there. So that quick treatment, that's going to help not only with mortality, but also with the long-term likelihood of repeated seizure activity. So the longer you leave seizures uncontrolled, the less likely it is that they'll be treatable. So that early treatment is really important. Comparing seizures that have been going for 1 year versus 4 years, those that have only been going on for a year or less, you have a 60% chance of being able to control them pharmacologically. At 4 years though, now it's only about a 10% chance. So wait and see is not a great approach for seizures. Those need to be controlled quickly to avoid death and also to avoid what we call kindling, or the worsening of seizures, which we'll get to in this part of the talk. So when we're talking about seizures, we're talking about bursts of activity from a large group of neurons. That's all it is, and we can detect that with EEG. Now there's a number of things that can cause bursts of neuron activity. It could just be heat, and that's what we see in febrile seizures. So when the child gets hot, it's going to hyperventilate. That hyperventilation is going to increase the pH. I'm sure you've heard of this before. Bicarbonate buffering. So when carbon dioxide levels rise, this is going to create carbonic acid that then breaks down into free acid and bicarbonate. If you haven't heard of this before, this is how your blood keeps its pH. So I know you've heard of this. When we have hyperventilation there, CO2 levels are going to drop. And that is going to increase the pH by decreasing the amount of free acid because you'll notice this is in equilibrium. It goes both ways. Decreased carbon dioxide, the Chatelier's principle tells us, we're going to drive the reaction this way, and so we should also get a drop in acid. So an elevation in pH. That elevation in pH causes an increase in what we call HCN current. And you're going to love this. You're going to hear about these next semester. These are excitatory currents that are activated during hyperpolarization so that neurons can pacemake. So when they hyperpolarize, HCN current excites them. So when we hyperventilate and we're hotter, so our metabolic rate's going to be maybe a little higher, probably not too much, but a little bit. That drop in carbon dioxide increases the pH and then increases the degree to which neurons depolarize following that action potential. So they get greater excitatory current, leading to more rapid bursts of activity. And that's what these data are showing us. So HT would be heat treatment. And the 4 different panels are great. You can just look at the bottom right. What they're doing is hyperpolarizing the cell and bringing it back up to normal temp. I'm sorry, not temp. They're hyperpolarizing it and then bringing it back up to rest. When they heat up the rat before they do this, and they give it that hyperpolarization and bring it back up, you'll see a spike with the HT. They spike after that hyperpolarization because they're more excitable. But whenever they heat the little rat up and they deliver 5% carbon dioxide to keep carbon dioxide levels the same, they don't change the pH, they don't change their HCN current, and you don't see a spike. So that could be what's going on with febrile seizures, head injuries, mass lesions, again, just pressure. So mechanical gating, inflammation can also hyperexcite neurons through all the ways that we talked about in lecture 3, I think. Cerebrovascular disease, again, we already went through that. It could be inappropriate potassium buffering too. So we do see some channelopathies, so we see mutations in potassium channels, sodium channels. And potassium is especially important because neurons are most permeable to potassium at rest. So changes in extracellular potassium are going to affect the membrane potential the most. So here's our happy little neuron. Now, ions are moving across at rest. You know, it's resting. It doesn't mean it's doing nothing. It's just not firing an action potential. Now, predominantly what's going on is potassium is leaking out. And that's what keeps us hyperpolarized, somewhere around -70 millivolts. That constant leak of potassium. When we have a buildup of potassium outside, well, it's harder to leak out. We don't have as much of a diffusive force. If we're not leaking out positive charge, we're not going to be as negative. So that's what this illustration is showing us here. So that on the top left is just saying the neuron's a big bag of potassium, and that's pretty well true. Going to the right of that, you'll see a plot. And on the X, we're looking at the concentration of potassium outside the cell. And on the Y, we're looking at membrane potential, sort of. We're actually looking at the reversal of potassium, but that's okay. Think of it as membrane potential. And here's rest. Normally we're at about 3 millimolar. But hell, you can detect upwards of 10 or even maybe 15 millimolar during a seizure activity. We'll say 10. That is going to bring us from rest well above our threshold potential. So we're going to see depolarization when we increase extracellular potassium. And we'll talk about why next semester. Coincidentally, or not, you see an increase in extracellular potassium during the tonic and clonic phase of seizures. I believe these were induced by canic acid. So they put in a molecule that's going to stimulate glutamate receptors. And in doing so, it excites the neurons and they fire action potentials. There's a little burst of it and there's a prolonged burst there during the clonic phase. During that burst, you'll notice elevation in extracellular potassium, and that's what panel C is showing us. Now, one of the areas that's especially prone to seizure activity would be the hippocampus. The hippocampus is where we store our memories. It's where we link together our day, and that's why we'll see complex seizures. If you essentially short-circuit the hippocampus and cause it to burst fire, not based on what's going on in the world, but just from intrinsic excitability of the neurons, you're not going to remember what happened. So there will be a loss of consciousness as a result. You won't remember what happened during the seizure. Now, one of the things to keep in mind about the hippocampus is that the neurons there are highly excitable, and that is why we're able to remember, but also why it's prone to seizure activity. Now, one of the reasons that they're so excitable is because their dendrites can fire action potentials. Not just their axons certainly can too, but their dendrites can also fire action potentials. So when these neurons are active and they fire their action potential here in the axon, we get what we call back-propagating action potentials that travel up through the dendrites. And that's what these data here are showing us. So that's most likely a biocytin-filled pyramidal neuron in the hippocampus. They're recording the membrane potential in the cell body. That's what the V-soma is in panel B. And then they have 3 different regions of interest, or ROIs. ROI 3 is out there furthest away, then 2 is where the apical dendrite there bifurcates or splits, and then ROI 1 is there near the cell body. In those regions of interest, they're just looking at calcium signaling there. So they're looking at a calcium wave that moves through the dendrites. Because the dendrites, for the most part, are going to fire calcium-based action potentials. And this is really important for learning, most likely. So the dendrites are excitable, and as such, the neurons are more excitable. Now, normally we're going to have some GABA input that's going to suppress these action potentials unless there's some additional excitatory input, but let's not go down that rabbit hole. All the data down there are showing us is that whenever you block GABA receptors, you see an increase in the excitability in the cell body and all along the dendrites, and that back-propagating action potential makes it all the way up into ROI 3 in that case. And every time we have these action potentials, we're also going to have efflux of potassium. And what you'll notice if you take a look at a few hippocampal neurons, there they are right there. This is from the rainbow mouse. They call it that because the brain kind of looks like a rainbow of colors. They've put in a bunch of fluorescent proteins that give each neuron a unique color, so you can look at many of them at the same time. And notice those strands, those dendrites that are all running in parallel. So whenever we're spitting out potassium, as that action potential moves through the dendrite, we're dumping potassium on a big area of our neighbor. And since they run in parallel, as opposed to, let's say, being perpendicular, if they were perpendicular or something not as close to parallel, they'd only have a very small region where they're close enough to excite each other, as opposed to long regions. When you excite more of the membrane, you excite more of the neuron, you produce more robust depolarization. So those back-propagating action potentials, they're really cool. We'll probably talk about why they matter for memory next semester, but they also matter for epilepsy because they make hippocampal neurons more excitable. Now, the hippocampus is going to be widely connected with the cortex. That's how it integrates so much information and pieces together every aspect of our day. So when you have hyperactivity in the hippocampus, that can lead to hyperactivity elsewhere. There's a few different ways that the hippocampus is connected. What we're looking at here is one example. This is the Papez circuit, where the hippocampus moves around via the fornix, hits the mammillary bodies to the thalamus, thalamus to the cortex. The hippocampus can also project to the entorhinal cortex, and then that projects then widely to the rest of the cortex. Now, the hippocampus is where we learn. It's a highly excitable region. It's where we rewire synapses. Remember, fire together, wire together. That's great for learning. It's a really unfortunate logic to use, though, in the case of seizures, because in a seizure, neurons are firing together. And so what we might expect is that seizures get worse over time, and that's what we see if you don't treat them. So allowing recurrent seizures to continue along causes what we call kindling. And this is likely the exact same thing as LTP, but people will argue ferociously about them being different or the same, so who cares? They're basically the same thing. They're both saying there's an increase in synapse strength because neurons are firing together. That's all it is. You can call it whatever you want. LTP, kindling, sensitization, I don't give a shit. It's the same thing. So in the hippocampus, we see a lot of this synaptic plasticity. We'll call it LTP, we'll call it kindling, same thing. We see neurons firing together and as such wiring together, and they're very likely to fire together because they're so excitable. That's great because we can store information, but when you have seizures, it's not so great because you see what you're seeing there in those data. So here they're just giving different injections of a GABA antagonist. It looks like let's see, pentylene tetrazole. There we go. PTZ, pentylene tetrazole. And every time they give one of these injections, we're going to see seizures. And what you'll notice is that as we give a greater number of injections, the numbers are slightly different there because I'm making all this up. Here we're going to see the seizure severity. This is okay, and this is bad. Injecting nothing else but a GABA antagonist, you see worsening of seizures. So that's what that top line there is showing us, the one that gets the most worse. There is your learning. There's your kindling. Because those neurons are firing together, they're more likely to fire together in the future. So the seizures get worse. They continue to recruit more neurons into their network, and now more neurons are firing together, and you get a worse and worse and worse seizure. If we were to treat with a GABA agonist, that's what we're seeing there with diazepam, so that's a benzodiazepine. Here we're going to increase GABA receptor function, so we're going to cancel out that PTZ injection there. That's your flat line on the bottom. Stays okay, no kindling. We keep our neurons inhibited. There's two lines in between there where they're putting some mysterious plant compound on. They think maybe it's a GABA agonist because of this, and they're trying to spin it as being useful for epilepsy. And maybe it is. We don't use it, but maybe someday. Anyway, the point is here, when neurons fire together, they wire together. And so if you allow them to fire together many times, in other words, if you don't treat seizures, they will wire together, and the seizures will get worse as a result. Now there are treatments, and the majority of the time anticonvulsants are going to work just fine. So inhibitors of sodium channels or calcium channels or GABA transaminase, which is going to make glutamate from GABA. By inhibiting GABA transaminase, we have more GABA around, there's less glutamate as well, so we're biasing our nervous system toward more inhibition than excitation, and that's great. That's what we want in the case of seizures. When those don't work, then surgery becomes an option, and it kind of depends on the type of seizure whether or not surgery is going to be appropriate. If the seizures are focal, and we have a very select area that's affected, usually we can go in and treat with surgery. We could do resection, we could just cut it out. But what if you have, let's say, a focal seizure right there in your primary motor cortex? Well, that's a vital part of the brain. We don't want to remove that. then we won't be able to see, or I'm sorry, we won't be able to move anymore for that area that we just removed. So resection, or just removal, that's not going to work. All right, resection is what we're seeing on the left here. Here they just attach little tiny electrodes and they look to see which areas are having the epileptiform activity. Let's take only those out. And then they cauterize the wound. That'd be the nice grill marks that they have on there. But you can't always do this. So if it's a vital area that we need to preserve, what we're going to do is multiple subpial transection. So what we're going to do is just make some cuts right there at the surface. We're just going to make a bunch of cuts. And what we're going to do here is cut those local fibers. So neurons in the cortex can project deeply to get to the spinal cord so that we can move, but they also, some of their neighbors here, are going to project more locally, nearby. And that is what's going to spread the seizure activity throughout. And so by making these multiple subpial transections here, we're going to cut these axons but preserve the deep ones so we can still move, but we reduce the spread of seizure activity. For general seizures, obviously surgery doesn't have great options. One of the things that we used to do is cut the corpus callosum. So that's the white matter bundle that connects the two hemispheres. So in a callosotomy here, we're going to sever the corpus callosum, so that fiber bundle that's going to link everything together here. So when you have seizure activity on one side of the brain, at least it doesn't spread to the other. This creates a number of problems for the patient, such as difficulty coordinating both sides of the body, but it's likely better than the severe generalized seizures. This is really only going to be useful in older patients. We tend not to do this in younger patients because it doesn't really work that well. You still have your generalized seizure going on. In the case of very young patients, we do a hemispherectomy. So what we'll do, rather than cutting just the corpus callosum, we'll actually remove one of the cerebral hemispheres. So they'll operate with half a brain, and yet surprisingly they'll still acquire normal function. I'm not sure how this plays out much later in life in terms of dementia onset or things like that. But even though language is lateralized to one side or the other, if this is young enough, they'll still learn. So the hemispheric specialization is clearly not set in stone. Another option that's fairly new would be deep brain stimulation. So in this case, they're going to use deep brain stimulation in the anterior thalamus. Let's take a step back and remind ourselves that we've seen the anterior thalamus. Notice this is one of the waypoints between the hippocampus and the cortex. So if that hyperexcitability in the hippocampus is going to make its way to the cortex, it has to pass through the anterior thalamus. Deep brain stimulation, of course, sounds like it's going to stimulate the brain, but it doesn't, so it's a misnomer. This is more like deep brain inhibition, so we use a stimulating electrode to hold the neurons essentially too depolarized to be active. So we're going to inhibit the thalamus. Despite calling it stimulation, it's not in this case. So with deep brain stimulation, we inhibit the anterior thalamus, and in the overwhelming majority of the cases, we have a substantial improvement in seizure cases. So the x-axis here is just showing us the seizure frequency, and it's going to be percent change from baseline. So 0 there, that 0 bar showing us no change. They are just the same. So everything that's to the left there means that there's been a decrease in seizure activity, and you'll see there's more than a handful of cases where we have 100% reduction. So they're gone. There's, of course, most of them that are going to be somewhere between 100 and 0%, The median of all the subjects was what looks like a 69% decrease there in seizure activity. And then there's 6 cases that actually had worsened seizures, but all the remaining cases had a decrease. So each one of those bars is showing you a different patient who had an anterior thalamic deep brain stimulator implanted. This has, I think, 1 or 2 years ago been approved by the FDA as treatment for epilepsy. So when the drugs don't work, we have options. The nice thing about deep brain stimulation is that you can always turn it off. You will cause damage while you're inserting the electrode, but once it's in place, you can turn it off or turn it on, doesn't matter. It's a switch. So if it's not working, if it makes your seizures more severe, just turn it off. If it helps, leave it on. And there can be adjustments made, unlike surgery. Once you've gone and cut out a part of the brain, it's gone. So that's a little more final there. Speaking of final, we're done. That's all we have for this lecture here. I have some review questions for you here. Review those. Anything that's not clear, fill out the questions box or bring it up whenever we meet together. I'll see you later.